All right. Welcome, everyone, to our weekly Wednesday morning Grand Rounds. So today we have the honor of having Dr. Jennifer O'Donnell as our Grand Rounds speaker. Dr. O'Donnell is one of our fourth-year residents here at UCSF. She's originally from New Jersey, went to Dartmouth for undergrad, where she studied physics, biology, and then was also the captain on the soccer team. She went to Rutgers for medical school, and then did research at University of Cincinnati as well before coming out here for orthopedic surgery residency. She has excelled as a resident. She is an aspiring spine surgeon. She will be completing her spine fellowship at Emory after finishing up residency here. She has served as our departmental representative for the California Interns and Residents Union. She has done a number of different research projects with a strong focus in spine. She's won a number of awards from OREF, has had grant funding from a number of spine societies, and has done a great job as a resident, and will be speaking to us today about cost awareness in orthopedic surgery. So, Dr. O'Donnell, thank you for speaking today and look forward to your talk.
Good morning, everyone, and thank you for the kind introduction. This morning, I'll be discussing cost awareness in orthopedic surgery. I have no disclosures. Here's a brief overview of some of the topics I'm going to cover this morning. I hope to first define the terms that I'll be using, set the scene for the context of surgical costs, and discuss the state of cost awareness in surgery currently and what we can do about it. Put simply, it will be the what, why, how much, and what can we do? So what is this concept of cost awareness? I'll start here with a few questions to get you thinking about this topic. For residents and faculty alike, I'd like you to think about what was the cost of the last surgery that you did? How much was that last implant that you used or last suture? Or maybe something easier, what is the difference between the implant that you used and another implant that was available? These topics are things that I've been thinking about over the last year, especially as I'm moving closer to beyond residency, thinking about making these decisions. Also, while I was in Tanzania, this is something that, of course, was brought up even more and sparked my interest. So what is cost? Aside from being the elephant in the room that we don't want to talk about, costs can be very difficult to define, actually. And even more difficult, and something that we're even more uncomfortable with, is talking about cost when it may feel like we're balancing costs with outcomes. This is a really immense topic, and so today I'm going to focus on reducing costs. That is the cost to the hospital, which then trickles down to the patient, their insurance provider, and ultimately all of society. But I want to emphasize that we're going to focus on being cost aware, but always keeping our patient and our outcomes first. Adjacent to the idea of cost awareness is price transparency. So for some definitions, cost awareness is on the provider side, our knowledge of and consideration of costs when providing treatments. Price transparency is on the consumer end, the availability and accessibility of prices for our patients or also for our hospital administrators. Cost awareness has become increasingly popular in the research as shown here on PubMed, but also in discussions on healthcare economics. For some context, I'll paint the scene for something that many of us are familiar with. Healthcare costs are rising, and it's over $4 trillion in 2021. A large chunk of that is hospital care. So that's in-hospital, inpatient stays, surgery costs. Altogether, healthcare costs make up over 20% of our US GDP. Orthopedic costs are also on the rise. Among medical devices, as you can see here, we make up about 1/4 of the market. The orthopedic device market was above $53 billion in 2021. To put that in comparison, the cardiovascular device market was $51 billion. So we're even more than that. So what? You may be thinking, whether you were in the grocery store and saw the price of eggs or rent in San Francisco, things go up with time. But not everything goes up. As we're taking care of more patients, we're serving a higher volume, we're increasing our efficiency. We're using things like telehealth, technology, shorter stays, minimally invasive surgery. Shouldn't we be bringing our prices down? And we see this with a lot of technology in different industries. The first computers were millions of dollars. Now computers are very accessible. So what makes healthcare different? Simply being cost aware is not the only thing at play here. It begins with limited price transparency. That then inhibits our ability to be cost aware. And we can't be cost conscious if we don't know what the cost is. And then there's an ongoing ethical conflict between providers, hospitals, insurance providers, and industry. And above all, what makes healthcare different is that our goals are not aligned. For us surgeons, our primary goal is the patient, not the cost. This editorial in JBJS came out last year and discussed this exact topic. The authors highlighted our ethical pillars as doctors. That is beneficence, non-maleficence, autonomy, and justice. However, none of these directly discuss the issue of cost. They posited that non-maleficence, not doing harm to our patients, also expands to financial harm. More than 1 in 4 Americans have trouble paying their medical bills, and medical bills are the #1 reason for personal bankruptcy in this country. Additionally, the concept of justice also is related to cost. Patients, as we're treating more patients, we would be able to treat more if we had our costs lower. Part of the difficulty of being cost aware is that costs are not only rising, but they're also highly variable, and they're not well understood to us or to patients. And lastly, cost is not the only thing at play here. We can also discuss value. Apart from country to country or even state to state, we see variation of cost even within a single metropolitan area. For example, the price of a total knee in San Antonio alone varies from the lowest to the highest, a 3 times difference. Within Dallas, it's a 4 times difference. And across different cities, like from Iowa to New York City, it's more than 3 times difference. In addition to variation, cost is a very muddied picture. It makes it very difficult for us to understand. What should be simple: take the cost of the implant, the cost of their care, and the cost of the people and everyone's overhead. That should give us our surgery cost. But it's just not this clear. There's many other things that are involved, and costs can vary from hospital to hospital depending on different contracts, supplier costs, and the setting of the hospital as well. And lastly, the term cost alone does not tell the whole story. We can also discuss value. If we lower our costs and keep quality the same, then we're actually increasing value of our care. And as recently as this month, in CORE, the concept of value-based healthcare continues in the literature. We also must understand the regulatory landscape of cost awareness. Before I describe some of these laws and acts, has anyone heard of any of these? Great. Based on my survey, half of us have not heard of the Stark Law, and I had not heard of it before doing this talk. So I'll briefly review some of these. And each of these has attempted to control overspending and provider-industry relationships in healthcare. First, the Sunshine Act, which is also known as the Federal Open Payments Program, mandates that providers with any industry relationships are listed in the Open Payments database. The Hospital Price Transparency Final Rule mandates a similar program, but on the hospital's end. Hospitals must provide pricing publicly to patients. And lastly, the Stark Law made it illegal to self-refer for financial gain. Regarding the Sunshine Act, about 1/2 of U.S. orthopedic surgeons had industry financial relationships in a recent article. That puts us ahead of most specialties, but behind plastic surgery, urology, and neurosurgery. Another study 1 year later found closer to 70% of all active orthopedic surgeons were listed in the database. What they also found was that most people had small relationships that were bringing in a small amount of money, and then there was a very small group of people that had higher payments, mostly royalty payments, making up the majority of the cash flow. Meanwhile, the Hospital Price Transparency Act, this is one that has been fraught with problems. It was established in 2021, and this recent article evaluating its efficacy showed that it had low compliance, about 30% across different hospitals. It was ineffective in actually lowering hospital costs, and cash prices were often better than commercial prices, which patients did not like to see. Lastly, there was wide variation in cost across hospitals. Importantly, they found what was the cause of people not complying, of hospitals not complying. And this was discouragement. And this was coming from other hospitals in their area, practices in their area, and insurance companies. This is hurting not only the consumers, but also the hospitals. Price transparency actually has been shown to attract more patients, and hospitals that did comply had higher volume. So how did UCSF perform on this? Well, a quick Google actually brought me to our page, so that was pretty easy. And then it allowed me to download this Excel sheet that had thousands of items, everything from x-rays to blood tests to one night in a private room versus a regular room. I was able to see all of these prices. Additionally, UCSF had a very nice feature in that I could put in an estimator what my surgery was going to cost me. Within a few minutes, I was able to get a quick estimate for an out-of-pocket knee meniscectomy. If I wanted to put in my insurance, I could also see what that took off. As you can see, I got a very nice discount for paying cash. Still too much, so I think I'll pass. Beyond making prices transparent to the end user, the patients, making them available to surgeons and hospitals allows us to know if our hospital is getting the best negotiated prices and what is the difference between different implants. It's incredibly difficult to find this data. I was able to pull it from a Medicare database called the Orthopaedic News Network, which is a subscription that you can obtain. As you can see here, there's different pedicle screws, different distal humerus plates, and different tibial nails, just for a few examples. And you can see these prices are pulled from hundreds of thousands of cases. And so we can get a better idea comparing to our prices at UCSF if our hospital is getting the best price, and then also can see among different manufacturers which ones are much more, and is the clinical difference in those two plates worth it? I hope I've given some background into where our surgical costs fall in this complicated landscape. Now it's time to look at ourselves and ask, are we cost aware? And this applies to us in many ways, as a society, as doctors, and as surgeons. First, there are some cultural issues which we as orthopedic surgeons are not immune to, and neither are our patients. For one, we tend to think that bigger or more expensive is better. And many studies have shown people will buy things just because they are expensive. And even more studies have shown that people will like something more just because it's expensive. A really interesting study that I came across illustrated this point. They had two groups drink the same bottle of wine and put them in an MRI scanner. One group was told it cost X amount, and the other group was told it cost twice that. And they all tasted the same wine, but the ones who thought it was more expensive, their brain MRI actually lit up more in their pleasure centers. As it pertains to medicine, another study, equally interesting, they took participants and everyone was given placebo pills, but they were all told they were pain pills. And two groups, one was told that the pills were $2.50 each. The other group was told that the pills were 10 cents each. Then they gave them electrical shocks. And the group that had the more expensive placebo, despite all of them getting placebos, that group was able to endure more shocks. So it shows that our concept of bigger or more expensive is better runs very deep. We also all suffer from a blank check mentality. You go to an all-you-can-eat buffet and you're going to eat more because you've already paid and you want to get your money's worth. Many studies in the psychology of economics have shown that if we pay up front, we're more likely to take more or eat more to make up for our payment. This is similar to healthcare in that we pay for our premiums, and when you do go to the hospital, you want to feel like you are getting your money's worth. Lastly, the concept of shared sacrifice is very difficult in society. If we think about recycling or conserving energy, no one individual wants to make a sacrifice that you don't see others making. Overall, these concepts and these tendencies as humans are all innate to our society. I wanted to review all of these to emphasize that there's no difference between us or our patients. We're all susceptible to these tendencies. And these issues exist outside the US as well, with poor cost awareness in almost every country where it is studied. But the US consistently is worse than all other countries. As depicted here, cost estimates across a variety of countries for common surgical items were accurate only 13% of the time. Cost awareness is also poor across all medical specialties. They asked ED physicians to correctly estimate their most commonly ordered tests and used supplies. They were only right 14% of the time. Looking at general surgeons, their cost awareness of the most basic surgical items that they use in every case was less than 25%. And burnout was associated with worse attitudes towards cost consciousness. Burnout, as we know, is on the rise among physicians, and this does not bode well for our cost awareness in the future. Looking at orthopedic surgery, our numbers are staggering. Again, the implant market has surpassed $53 billion annually. However, we are not cost aware. We seem to recognize that we are not cost aware, as our self-rating is poor in more than half. But our estimates of costs of implants are off by 50% or more for all implants. That is, when asked about every implant we use, not a single one are we closer than 50%. Additionally, relative cost estimates, being asked which one is cheaper and given two options, are equally poor. Calling back to this article in JBJS from last year, where this ethical dilemma is explored, our issues with cost awareness may stem from the poor price transparency that exists. Regardless of the cause, not knowing the cost affects our ability to care for our patients in the best way possible. Cost awareness is also multifaceted. Like I've mentioned, there's surgeons, trainees, and patients. Let's look at each side of this. First, as surgeons, we underestimate the most expensive items, and we overestimate the lower priced items. Unfortunately, we also don't seem to want to consider cost in our decision-making. Most of us want to put our outcomes first, and that's obvious. But even when cost is known and different implants do have clinical equipoise, we are still resistant to considering costs. Among trainees, we do even worse. We are typically worse than all other surgeons, all attendings. And even among those who are cost conscious, we're not cost aware. Senior residents were surveyed on their graduation and were found to care about cost, but they were very poor at estimating it. Other studies have found that all members of the surgical team have poor cost awareness, from the scrub techs to the residents to the attendings. A few ideas on why residents may be worse is that we don't receive any training in this. We may get some on the job kind of mentoring, but we don't have any formal education. And in some way, residents may not have the capacity to also learn about this. We're learning about a lot of things while we're in that OR. And overall, residents do understand that they are very poor at cost awareness. On the patient side, patients have poor cost awareness. They largely underestimate the cost of their total care, and they do not want costs to be factored into their care. And this goes back to our human tendencies against shared sacrifice, and as well as our tendency to want whatever is the most expensive, even if the options are actually equal. So how do we stack up? In preliminary data from a survey of our department, we self-rated our cost awareness from 0, not cost aware, to 100, very cost aware. We fell all over the map, literally ranging from 0 to 100. And the mean response actually fell right around 50. As shown in previous studies, we overestimate lower cost items. Here we have a C-armor drape, 30 cc's of allograft, and a K-wire. And the red line represents the true cost per the UCSF surgical receipt. You can see most of the dots are falling above the red line. And we also underestimate the higher value items. Here we have a total hip polyethylene liner, a package of BMP, and a short cephalomedullary nail. With the exception of the short cephalomedullary nail, which we actually did pretty good at, we mostly have our dots below the red lines here. With all of this information about cost awareness, what can we do to improve? There are, of course, numerous levels on which this change can be affected. We have the whole culture, the innate human tendencies that I discussed earlier. On the hospital level, change can be driven more by policy and on an administrative level. And lastly, we have the one that is the most in our direct control, the surgical level. I'll focus here. The main domains of improving cost awareness are educational interventions, finding and implementing alternatives, and reducing costs by reducing waste. However, let us not forget that having good surgical indications and thoroughly examining all non-operative options first is not only good for our patients, but can also reduce costs. Beginning at the smallest level and working our way up, let's try increasing cost awareness. Now, awareness alone does not always create change, but in the case of cost awareness, by simply educating surgeons, costs per case are brought down. This has been shown in a variety of fields. First, in thoracic surgery, as shown here in this infographic, information was given to all surgeons on the costs of their disposable items, as well as cost reports after each case were automatically emailed to the surgeons. They looked at 150 cases before this intervention began and 150 after, and they found cost savings of about $750 per case and no differences in clinical outcomes. Additionally, in general surgery, this has been shown as well for appendectomies, bringing down costs by about $1,000 per case. How about in orthopedics? Well, an intervention was performed in a spine department where they looked at the cost of each package of BMP. They gave this to the surgeons, educated them all on the different sizes that are available and the price of each size. Before the study intervention, shown here in black, you'll see the most popular size was extra small, and the second most popular was a large. After the study intervention, surgeons began using extra, extra small, a size that it seems they did not know they had. We also had average savings of $2,000 per case. At our own institution, costs have been made available in the electronic medical record. to all members of the surgical team. This is occurring at both Zuckerberg San Francisco General Hospital and UCSF at all sites. At UCSF, it can be found under the post-op tab quite easily. And at Zuckerberg San Francisco General Hospital, it will come up as you're entering your post-op orders and brief-op note. It shows not only the absolute cost of every single item that you used, everything from gloves to suture to the implant, but it also shows your relative costs to yourself, your own average, and other surgeons doing similar surgeries. Unfortunately, not all of us are utilizing this tool. When asked if you are aware of the surgical receipt, 34% of our department was not. Of those who check it, not many felt that it changed their management, only 18%. But if shown the receipt preoperatively, people felt it would help them make choices, especially regarding implant, with 74% answering yes to that. So again, our ability to be cost aware will help us make more cost-conscious decisions. Another interesting educational initiative was rolled out at a different institution and had a similar idea, letting surgeons know the cost of their implants. Implants were all scored relatively. They were given a red, yellow, or green based on the relative cost. Green were more preferred vendors, and red were supposed to be used only when absolutely necessary. However, all surgeons were still free to choose whatever implant they wanted. This chart was then posted in the operating room, as these were all trauma implants, so decisions could be made as the case was being booked. Cases before and after the implementation of the chart were looked at. The authors found that this simple chart alone propelled very significant change. As you can see, moving from the left to the right, more green implants were being used and less red were being used. As a bonus, the authors noted that vendors were becoming very competitive about not wanting to be the red implant. Their companies were constantly approaching their hospital administration to offer lower rates. So this created a good culture in which people did not want to be red. Everyone wanted to get into the green. Moving beyond cost awareness, the next step is providing and implementing higher value, lower cost alternatives. Generic providers have become a disruptive force in the pharmaceutical space, with the Cost Plus Drug Company as a prime example. This company provides generic versions of drugs. You can look at their prices, and it's transparent, fixed rate markups. But would this work in orthopedics? Well, disruptive innovation is not a new concept. We use cheaper, simpler technologies in a variety of settings. For example, the sign nail, which is used heavily in lower and middle income countries or places where resources are lower. The mini C-arm, also as discussed in this article about disruptive innovations by Drs. Hansen and Bozic, as well as other alternatives such as X-Fix instead of intramedullary nail, again, first pioneered in lower middle income countries. These disruptive forces are really important, especially in our exceptionally top-heavy market. Within orthopedics, the top 25 companies make up about 85% of the market share. The top 7 companies, which all have annual revenues greater than $1 billion, make up 2/3 of the market share. Regarding generics, there are in fact over 20 companies that provide non-proprietary implant systems. Here are some examples to name a few. And one major difference with these companies is that many of them do not provide an intraoperative support person like a medical sales representative. And another huge barrier is whether there's clinical equipoise. Patient outcomes must come first. But the short answer to that is yes. There is both clinical equipoise and major cost savings across a variety of implants, mostly trauma implants, which have been studied so far. A JOT study used generic implants at this level 2 trauma center. They switched over to every single locking plate was now a generic, and they found reduced costs with no change to patient outcomes. Costs dropped by about $1,200 per case. Looking at cannulated screws for hip pinnings, there was 70% cost reduction with no clinical differences. Then looking at high-value external fixators, there was 58% cost reduction, about $2,200 per case. And lastly, tibial intramedullary nails, there was about 40% cost reduction, around $700 per case. And again, with all of these, there were no clinical differences. Moving into our next area for improvement, reducing costs, trimming the fat, I will briefly echo what Dr. Churches spoke to us about last week. Both cost and waste can be tackled at the same effort. When we reduce waste, we also reduce costs. In this article, a hospital system approached its residents for ideas on cost and waste minimization. The best proposals were then selected for implementation during a study period, and efficacy as well as cost savings were studied. They chose 7 major projects to implement, focusing in the 2 main domains of minimizing waste and optimizing patient care. They minimize waste by reusing drill bits, improving their supply packs, eliminating just one excess downsheet, and being more selective with tourniquet placement. They also had stricter algorithms for when to order CTs for long bone fractures, as well as ordering PT consults for isolated lower extremity injuries. They found significant annual savings associated with all of these, amounting to over $10 million annually. These are small examples, but again, they can help with both waste and cost. I've presented a lot of things big and small for us to think about as orthopedic surgeons. We can help reduce cost, waste, and improve cost awareness, and hopefully improve outcomes at the same time. But we can't ignore the fact that surgery itself is costly. One of the best ways to reduce cost would be to judiciously order tests and perform procedures. The Choosing Wisely campaign and clinical practice guidelines are ways that we can do that. Choosing Wisely was a campaign began in 2012 by the American Board of Internal Medicine Foundation, and they've partnered with many specialty organizations, including our own. Choosing Wisely allows us to not only not do surgery when we don't need to, but also gives us alternative options. And many of the AOS examples from the Choosing Wisely campaign follow our best practice guidelines, limiting the use of CPS machines, PT consults, and opioids, just to name a few examples. Now, there are a lot of barriers in our way to achieving better cost awareness and cost consciousness. There's the culture, which I've mentioned, surgeon perceptions, and patient perceptions. First, at the culture, I hope I have provided some examples on how we can make changes. We have our own surgical receipt here at UCSF, and examples such as the interventions that helped with BMP and the red, yellow, green chart, which could be adopted at our own hospital. Lastly, the Choosing Wisely campaign, as well as our best practice guidelines, can help guide us. And incentivizing cost awareness is the next step. Now, as surgeons, we have our own conflict of interest. We like to operate. We are surgeons. Even if we're not paid per case, we still have that moral hazard. Another issue is inertia. It takes a lot to change people from the way it's always been. Switching to an alternative company may also mean losing your intraoperative support as the medical rep. Regarding this, a study of OTA members queried surgeons on their use of a medical rep. A large majority had a rep present, but only 21% said they needed it. And 73% were aware of generic implants existing and being FDA approved, but only a quarter of them used them in their practice. The most commonly cited reasons for why respondents had not tried generics were that they were happy with what they had. And more so, there was no incentive to change. Not only are we hesitant about change, but there seems to be no reason to. Without incentive, people will not change. A JSES study of shoulder surgeons and sports surgeons showed that the majority of the surgeons were cost conscious, and they were actually willing to switch implants if incentivized. They were not currently incentivized, so none of them had switched yet. So how can we incentivize? We have gain sharing models, which have been discussed in JBJS recently. Also aligning the physician and hospital incentives. And bundled payments has also been a target as an opportunity for cost reduction, but has not borne out yet. Looking at our own department, how did we feel about incentivizing for cost reduction? A majority of people felt that incentives should be utilized. And most felt that the surgeon is the one who should receive the incentive, as well as the hospital or the department. Patient perception is another hurdle for cost consciousness. Similar to providers, patients are not aware of the true cost. Many studies have demonstrated that patients truly believe that a generic form of a pill or an implant does not work as well as the brand name. They are happy to spend more to buy their brand name medication because they think that it's going to work better. A study by Miner had shown in 2022 that the majority of patients trust their surgeon to make the right decision. And they even see the benefit in generic implants. However, for themselves, they do not want a generic used. This touches upon the issue of shared sacrifice, that we may think that generics are good for society as a whole, but we don't want it for our own surgery. There may continue to be barriers, but I hope that I have shown the importance and utility of cost awareness. It's important for both providers and patients, and cost awareness is imperative for us to do right by our patients. On a higher level, change must be advocated for. Continued regulation and changes to our culture can help make healthcare more transparent. And there's also large gaps in our knowledge in this area, especially among trainees. I believe education, whether formal or informal, early on in training would go a long way. And lastly, the changes that we make moving forward must be forward-thinking, disruptive innovation, and can ideally improve both patient care and reduce costs. Here are my references. Thank you very much. Thank you to all of the institutions where I've trained that have taught me about costs, as well as all of my co-residents and my family.
All right. Thank you. That was great. And I think it dovetails so nicely with what Dr. Church has talked about last week. So thank you both for...
Yes, not even planned.
I know that worked out really well. See a hand up from Dr. Freshman.
Hey, Jen, a great talk. My question is about kind of how cost relates to shared decision-making. We always talk about shared decision-making and how important it is to actually have a good relationship and good outcomes with patients. And I think it's good that we give price sheets and patients can look things up. But, you know, I'm assuming that I don't know what percent of patients would actually look at a price sheet before they come to the office. And I don't think anybody is really having the discussion of cost of what they're consenting somebody for a knee replacement or for, a ACL reconstruction. So are we truly doing shared decision-making in the office? And if we're not including the concept of costs into the conversation, but on the flip side, do we also have that ability to do that in the office in today's world?
Yeah, those are great questions, great points. There have been some studies that showed, they shadowed physicians in the office and looked at how often does cost come up. And while it doesn't come up in the obvious ways, it will be people saying, oh, I can't pay for that medication. Can you prescribe a different one? Can I get that generic? At least in the primary care setting where these studies have been done. Also, I would counter your question about discussing costs in shared decision-making. Do we ask patients which implant they want? Not generally. In general, patients are happy to let us make these choices. But I do think it depends a lot on whether they're bearing the cost. And I think that's what matters to the patient as well.
Jen, I was thinking of your slide about you're going to pass on the meniscectomy.
Yeah, I'll pass for now.
And I was thinking about, life is a circle and the far right sits right next to the far left. And how does one reduce cost? You can go to a nationalized health system, cross the border. Dr. Feely was commenting on how many patients come to see him because they don't want to wait. So that's one approach where it's totally controlled and it's out of the patient's hands. And that's a way to reduce cost. On the other hand, maybe we should go to the other extreme and be totally libertarian about it and make people pay more. And then suddenly their knee wouldn't hurt as bad. So as you look at this, which way those are opposite directions. Do you have a sense of which way we should be trying to go?
Yeah, it's my feeling that we are too far away from socialized medicine to ever get to it. But I think that we are probably closer to your copay or your payment being a percentage of your cost.
Because I think about the vets, the vets are really worried about insurance entering their field because already costs have gone crazy. Before you had to pay for your dog's operation and you thought a lot about it. Now suddenly the cost of veterinary medicine in America is on the exponential part of a curve now because they have insurance. It goes back to what you're saying is once I paid my premium, I want everything.
Yeah, absolutely. And I think a good answer to that is still having to pay a percent even after your premium. Then that would, kind of curtail people just spending because they already have the insurance.
And then you have great talk as well. Do you know within those surgery receipts, I think I've looked at them, but do they have like listed alternatives like built in there as well? I think about like the ways that it already comes up, like when I'm prescribing inpatient medications and you try to prescribe pantoprazole, it just tells you what the alternative is and you don't have to think about it twice. And that's probably because the hospital has some like contract with that company.
Yeah, that's a great question. And right now that is not part of the surgical receipt. You can see what similar surgeries or other surgeons have costed, but you can't easily, click on theirs. I think that could also be something that would be added in almost in the pre-op version of the receipt. That could show you alternatives, similar to how you're saying when you go to order something and it shows you an alternative.
Great talk. Thank you for somebody. No. Thank you for bringing some provocative thoughts. I just wanted to follow on the conversation about having a discussion with your patient about the implant. To me, it's far preferable if the institution negotiates a price so that, and it's a low acceptable price for the range of appropriate equipment so that when the patient and the doctor are having the conversation, they know that the items that they need are going to be there at a fair price. That's easier than talking about this implant versus that. And if it's that level of granularity, I think it's very difficult. The other point I wanted to make, and it kind of comes off of your comment about alignment of incentives. There's, and it has to do with the responsibility of physicians, or the responsibility that physicians feel, or the work that they're required to put in. If you think about lowering costs through outpatient migration as one example, who's taking care of the patients when they're not in the hospital and they need all this stuff before and after? Well, it's you. And there's a cost associated with that of time and effort and stress and everything associated with it. Mm-hmm. Same thing when we talk about generic drugs and generic implants. Well, with implants, there's this whole need for inventory control and knowing that when you measure something, you look up and say, I'd like the size so-and-so, that it's actually there. And I know everybody in the room probably knows the feeling when that isn't the case and how difficult it is. So the idea that it's just, why don't we choose generics because they cost less and they're equal? It's the service and the inventory management, the things around it are also important in our experience and our choices. And it's real. I'm not trying to be dismissive of that. It's really important, and it affects what work is like if you don't have that sense that things are there when you need them. So not making your job any simpler to sort this out, but there's a lot of complexity
Absolutely.
in the cost part.
Yeah. Thank you, Dr. Real.
Jen, that was great. That was really thought-provoking. I was just going to ask Dr. Kim and Dr. Kuo about how this works at the VA, if there are pressures to choose certain implants or make cost decisions, or if you sort of have more of a carte blanche situation.
I can answer a little about the VA. Just VA, there's a national contract. So then that negotiation happens at the federal level. Some of the decisions that are made are a little bit different than what we would expect, in the sense that it does prioritize U.S. manufactured implants. So for a trauma, hip stem for a hemiarthroplasty, if they are made overseas, they preferentially will not want that. At the individual level, there's a little bit of discretion from the standpoint that once it is on contract, there can be selection. The service component is that the VA does have national rules on things having to be there 48 hours in advance. So there's still that sense of you can't pick anything you want just because it is available. And there is a process to bring in new implants through local committees. And a lot of that has to do with inventory control, in the standpoint that we can't keep the instrument trays because we don't have enough physical space. And ensuring that, but the contract is done at a national level. So the price that we pay in San Francisco is the same across the United States.
And that price isn't necessarily the lowest you'd expect, just as with Medicare. In addition, as Alan mentioned, there are local committees that actually approve things. So even though something's on a national contract, doesn't mean that you necessarily can use it locally. And if you do, and you have a rep who brings it in, there's a lot of paperwork and a lot of trainings that we have to do. May I ask a question?
Yeah, absolutely.
So Jen, great talk.
Thank you.
In all of those studies that looked at generic implants and, green, yellow, red, who actually benefited from those cost savings? It wasn't the patient, wasn't the surgeon.
Yeah, most likely the hospital is the one who benefited. As you alluded to, the patient is not seeing any savings. The surgeon is not getting any sort of incentive. And so I think that's where we're at, with a little bit of a standstill for surgeons. Why would you take on the risk of using an implant that you haven't used before, that maybe hasn't been used as many times before, when the risk, the burden that you're taking on is entirely on you if it doesn't go well.
Thank you. That was an excellent talk. And the same slide of the cash payment for the mastectomy, that just makes my head explode, because it's such BS that a mastectomy is $40K, and all the transparency to try to say your drapes are $200, your sutures are $400. It's not. It's $13,000 plus a profit. Like, the profit is built into $13K. So why do we say it's $40K? And why is everything $40K and the Medicare pays 30 cents on the dollars? Just say it's 30% of, it just makes my head explode. Why? Do that?
I agree. I was amazed that they put in the discount for the cash pay, because they know I can't pay $40K. So they gave me $13K.
It doesn't cost $40K.
No, obviously. Yeah, no.
You can just get rid of the $40K, and can we start the conversation at 13? I don't know. Clearly I'm bad with money, but
I agree.
Jen, from remote, if it's possible to drop a quick question, because I've been hearing your responses, the questions, and I still come back to this question of the quality. And I hear Diab's kind of the circular who pays. You commented about the the benefit isn't to a particular person. Dr. Vale's comment about who bears the cost. There's always a cost that's still going to be somehow felt. And what I've seen and heard is, the hospital doesn't justify a specific implant company because the cost, the pure bottom line. But we can say, well, actually, this
company does certain things, they provide a different service, but the benefit doesn't fall to the person paying the cost. So I'm curious, when you think about sort of that cost benefit and the fact that when you're looking at these numbers, our numbers are purely based on, as just stated with Dr. Wistrek's question, on people's ability to see the money, and the money is coming from the hospital. So I'm curious what your thoughts are in sort of next steps, because we can't change one without getting a benefit for all. So I'm curious what your thoughts are when you look at sort of the societal cost of this healthcare, kind of to Dr. Bale's point, when somebody else is paying something that's not monetary, how can we really get to the true value at the end? Any thoughts on that?
Yeah, I think that's a really difficult question. Thanks, Dr. J. But I think that we are going to be at a bit of a standstill as a society until we reach some sort of tipping point where the cost of healthcare becomes too much for our society to bear. But we don't seem to be close. So,
Rosie, I don't want your head to explode, and I'm not sure I'm going to help, but just to understand why is it 40? Everybody in the room who's going to deal with budgeting in hospitals and expenses in your service needs to understand the concept of overhead. And it's the reason, and this is why this transparency thing between hospitals doesn't work, because you can't compare one hospital to another. They price things differently. The 40K is fully loaded. It's including the guy who's raking leaves in front of the hospital in the garden, and the you know what I'm talking about, the heating, the air conditioning, and UCSF has all sorts of overhead, and it's very expensive. And when they begin to then distribute that across things that they do, procedures that they provide, it elevates the cost significantly. The other thing we should bear in mind as orthopedic surgeons dealing with devices is they typically will place the overhead on top of the cost of the device. Not fair, but that's how they do it. So, a $10,000 device is going to have the institutional overhead of whatever it is, 40%. Now, any service that's using a device is paying a disproportionate share of the overhead. So you kind of have to be aware of that when you think about costs. So conversely, if you're doing a procedure where there's no device, there's no overhead associated with that, it's more cost effective for that reason. So just one reason, not that it won't make you less anxious about this, but it explains what's behind this.
It's kind of a question: are we kind of losing a little bit of the forest for the trees? By far the largest cost for healthcare is labor. So if you look at the real biggest costs out there, it's people staffing the operating room, recovering patients. So a lot of it's easy and quick to point out the supplies, but like Dr. Bale said, there's overhead items labeled on there. They can't charge for SPD. They can't charge for the people checking in your patients. They can't charge for a lot of the labor portions out there. And how much are you looking also on just the overall labor side of it and how efficient or the costs associated with it? Because that's by far the largest cost when you look at healthcare.
Sorry to ask another question. It's the dieting industry is also in the beta billions, when perhaps the most effective diet is just eat less. So why are we not talking about that more? We're so focused and we're just going crazy about generics and this, and I'm sitting there putting in large frag screws instead of a pedicle screw and torturing myself. I don't know if, we had a case we couldn't get them out and all the stuff, right? But maybe I just do one less operation every month, and then I can use all the implants I want to my heart's content, and I still might come out cheaper. In all of this, is there enough conversation about that? There's no question in America we operate too much. If you compare us with other Western societies, we give too much of everything, and maybe we just need to go on a diet.
That's a great way to put it. I think that is also the losing the forest through the trees kind of situation as well. Just being a little bit more judicious with your surgery indications could go a long way.
All right. I think we will wrap up there. But Dr. O'Donnell, thank you so much. And thank you all for being here.